Welcome to the second virtual panel of the conference, the COVID-19 Pandemic, Korea-Canada Comparison, Government Response, Social Welfare, Labor, and Gender. I'm Triun Lee, Associate Professor in Sociology and Director of the Center for the Study of Korea at Munk School at the University of Toronto. This event is organized by the Center for the Study of Korea at the University of Toronto and is generously sponsored by the Consulate General of the Republic of Korea in Toronto. I'd like to thank the Consulate General for funding this conference, and especially Counsel Wee Hyun, who will be joining this presentation pretty soon, I believe, who has been working very closely with me to organize these panels. I also want to express my gratitude to Hyun-Chul Kim, doctoral student in geography at the University of Toronto, who has provided research assistant, technical support, also creating the wonderful event poster that has been circulating around. Now, let me briefly introduce the background of the conference, which I already mentioned in the first panel, but just as a reminder, let me just revisit the background of this conference, and then I'll introduce the speakers for today. So the outbreak of the COVID pandemic since December 2019 has opened a new era and has completely changed what we once thought normal everyday life. The consequences were indeed unprecedented in terms of human lives lost, the halting of cross-border travels, lockdowns and closures, the shrinkage of market activities and economic downturns, and the list can continue. South Korea and Canada have not escaped these detrimental challenges, but from a comparative perspective, both of the nations have fared quite well regarding the number of cases, fatality rates, administrative leadership, and economic impact. As an unprecedented global crisis, the COVID-19 has directed us to re-examine and rethink about a number of important political and socio-economic issues, such as the infrastructure capacity and political accountability of the government, the strength and resilience of public health system, national crisis management, social welfare protection, information technology and digital surveillance, the right balance between public health and individuals' rights for privacy, new disparities that emerged, or old ones that got reinforced in the labor market, care labor and gendered responsibilities, anti-Asian racism, the continuing gap between the global North and the global South, among many other issues. So in the first panel held on October the 15th, we had Professor Ito Pang, Sociology, University of Toronto, who talked about the COVID-19 childcare and school closures and their impact on working parents. And Professor Youngjun Choi, Public Administration, Yonsei University, South Korea, who spoke about social policy responses to COVID-19 in South Korea. So today, I'm really delighted to have two speakers, Professor David Pt.2 and Dr. Student Triun Lee, who will present for 30 minutes each. For those who are participating in this presentation, please hold your questions to the end of the talk, and then I'll invite people who have questions in the order they appear in the chat box or in the order of raising their hand. So let me first introduce Professor David Pt.2, who is an associate professor in sociology and the Munk School of Global Affairs and Public Policy at the University of Toronto. His research lies at the intersection of political sociology and inequality. He recently edited volume 28 of Research in Political Sociology, which came out from Emerald Press. His book, published with Stanford University Press in 2019, was entitled Politics of Empowerment, Disability Rights and the Cycles and the Cycle of American Policy Reform. This book examines the back and forth relationship between policymaking and citizen participation. Currently, he's working with Professor Michelle Maroto and a research team of doctoral students on a project focused on COVID-19, disability, and chronic health based on an original national survey and qualitative interviews on which today's talk is based. So without further ado, please welcome Professor David Pt.2, who will speak about the impact of COVID-19 on people with disabilities and chronic health conditions.
Great. Thank you so much for having me. And thank you, Yoon Kyung, for that introduction and for inviting me and to the Center for the Study of Korea. I think this is a really important topic, especially in a context where a lot of people are kind of thinking and acting as though the pandemic is over. And I think that we are optimistic, and I think rightfully so. At the same time, I think there's a lot of questions that we sort of haven't addressed full on. And I hope that what I talk about today sort of really highlights what kinds of things we really need to be thinking about as we try to pull ourselves out of the pandemic. And it's both about health, but also about the economic consequences that the pandemic has had on people. So I'm just going to share my PowerPoint. I also wanted to thank my colleague, my longtime colleague and friend, Michelle Morato at the University of Alberta. And we did work to incorporate a lot of graduate students in our various projects. Martin Luck, who's a PhD student in sociology here at University of Toronto, has been at the forefront, and we published numerous papers, and there's a different sort of relationships between authors on these different papers, but it's definitely been a collaborative effort. And I just want to start by putting these very almost sort of scary headlines, just because it's a reminder that even early in the pandemic, it was already obvious, okay, that the effects of COVID-19 were not equally felt by people in the population. And very early, it was clear that people with disabilities and chronic health conditions were experiencing some of the most difficulties and challenges, not just when it came to health, but when it came to accessing programs and policies, that even the emergency response benefit that Canada enacted, and also just the access to other human beings. This is a group that's already vulnerable, already entering the pandemic in a more vulnerable place. So it was not surprising that these are the kinds of headlines that we were seeing. At the same time, surprisingly little was actually done to target this particularly disadvantaged group of people. So I think that's an important place to sort of start this conversation. Again, it's coming from a place of not so much surprise, but that the pandemic has reified or it just made more explicit things that were already in place. It's not that the pandemic created these especially new forms of inequality. And that's always been my position in studying COVID, is that this isn't just about COVID. It's about what COVID-19 illustrates about inequality, right? It's just that we pay more attention to it because it's more acute now. Okay. And so what I mean by basically what I've said about thinking about what COVID-19 has shown us is that this is a group that is particularly disadvantaged historically and presently. I mean, you just have to look at the employment rates, and this has been a policy issue for years, right? Policies try to improve the employment rate of people with disabilities, but in fact, in most places, some better than others, but in most places, people with disabilities are significantly disadvantaged. In the United States, it's around 30. The current employment is around 30%, which is very low, particularly compared to its peers. In the UK, it's around 54%. In Canada, it's about 50%. Okay, this is the employment rate. And just to show the extent to which people with disabilities do face challenges. Half of all complaints to the Canadian Human Rights Commission, which is the primary body that oversees discrimination complaints, it's basically the enforcement body, are actually disability-based claims related to the labor market. Again, half of all complaints to the Canadian Human Rights Commission, which hears complaints on race-based, ethnic-based discrimination, half are disability-based complaints of discrimination in the labor market. So again, another telltale sign that, things were not right before the pandemic, right? When people with disabilities work, they are more likely to be in low-paying, precarious jobs. In other words, usually jobs that are not unionized. These are often food and service sector jobs, right? We sometimes call it occupational ghettoization or occupational segmentation or clustering. There's many words for it, but basically it's that people with disabilities find themselves stuck in pretty crappy jobs when they are employed. And that goes a long way to explain why they continuously earn less than people without disabilities. Even in low-paying jobs, people with disabilities still get paid less for doing the same job that a person without a disability is getting paid. So it's a significant problem. Of course, employment is an important contributor to being able to have assets and wealth, right? But it's not the only thing. And in fact, if you want to think about insecurity more generally, it's not just about income. It's also about having assets, right? You can also have assets that that grow, that is independent of your actual employment income. But Canadian households with disabilities hold about 25% less in non-housing assets. And I say non-housing because, I don't want to go into the Canadian housing market, but, it's a strange market, but also that having a house isn't necessarily a solution to people's problems, especially when you need cash immediately. You can't just tap into house equity like that, right? I mean, I know that commercials make it sound like you can do that, but having a house is not necessarily an ATM, okay? So we looked at, this is just focusing on, this statistic is just for people talking about non-housing assets. That means this includes pensions and savings and any kind of other financial product that's meant to help people build a nest egg, basically, right? So they have 25% less than that. Low earning thresholds when it comes to government programs makes it really a challenge for people with disabilities to try to get a better job. So just as an example, in this province of Ontario, and of course in Canada, this is a provincial matter, disability really is administered by the provinces. In Ontario, with Ontario Works, which is an income supplement program, if you have a disability and you're on Ontario Works, you are allowed to work. But the income that you earn from that job is so low that as soon as you slightly exceed that amount, you are thrown off government benefits. So it actually has a kind of perverse effect of keeping people in low-paying jobs, because if they try to seek out a better paying job, they would lose the Ontario Works program and actually end up earning less. So it's actually quite perverse, right? And, like in many liberal welfare regimes like Canada, despite for example, variation in how our social safety net is, for example, maybe better than the United States and so on, there's still a very strong emphasis on a personal responsibility to save, right? I mean, basically, if you just look at what kinds of programs are there, they're all financial products that assume that people have money to put into them. Registered retirement savings plans, there's the registered disability savings plan, but these all assume that individuals at the end of the month have money to actually make use of these products. And that is generally not the case. So this is an important pre-pandemic context to sort of bear in mind, because this is where people were when we entered the pandemic, right? So it's important to sort of make that connection, because we do not all enter the pandemic in the same place. Okay. So what I want to talk about is very briefly just the methodology and the data, so that you know where we're coming from. The project has actually evolved because we did a second round of surveys with the same respondents, a subset of the same respondents, and we're still putting some of that together. So, everything's kind of evolving with the pandemic, and so it's just both exciting and challenging. So I'm going to talk a little bit about the methods, and then I have this divided in 4 outcomes. There used to be 3, but we just got results back on people's attitudes about economic insecurity. So I wanted to talk a little bit about that because I think it gets to a lot of where people think they're going to be, in a year from now, which is for a lot of people, they're not thinking very positively. So it's very telling about what people are thinking as we hopefully are exiting the pandemic. So I want to talk about employment and economic outcomes during the pandemic. I want to talk about people's perceptions of economic insecurity. I want to talk about their mental health, which is actually not unrelated to economic insecurity. As we show, there's actually a strong link between, having to literally deal with having the ability to pay your bills and stress and anxiety. And then I just want to wrap it up with a discussion on attitudes about policy responses and what Canadians basically thought about policy, and just a little note about how we kind of predicted a little bit how they would vote. I'm not a political scientist, and it was not a formal assessment, but it was actually pretty accurate from the sample about what people really thought they were going to do when it came to the recent election, which is actually not very much. And then I'll just want to provide some concluding thoughts about what does COVID mean more generally to how we understand the world, and what this alleged new world is supposed to look like when we exit the pandemic. And so that's basically the outline of the talk. Okay. So we conducted a survey in June of 2020. So we put the survey together actually in April. And I think just to get people where we were there, this is kind of really early. Canada had only in April and May were there really significant policy interventions by the government, whether it came to social distancing, and people were still trying to figure stuff out. So by June, it was the first real full month of, okay, we are on this path. This is what we're going to do in the pandemic. But you also have to bear in mind that depending on where you were in Canada, some provinces were loosening restrictions. Others were, like Ontario, were making them more tight. So it was a weird period, right? And so I think that it's important to note that because people here were far more optimistic. So these are more conservative estimates because they thought that by the summer, could you imagine? By the summer, people thought that things would be a lot better. But when we interviewed people, which started in the autumn, that optimism had largely disappeared. So again, it's an interesting facet of doing research, empirical work on something that's unfolding. So we thought that was very fascinating. It was very obvious. So we used a quota-based sample of 1,027 Canadians, and we hired Qualtrics to help recruit the sample. They are from an online research panel. So essentially, we give them an eligibility criteria, and they recruit participants for us. We were very careful with how we created the sample. We made sure that the sample reflected the way that Canadians are distributed across the country, because it was a cross-national survey. So our proportions of province, right, is basically roughly to what it is in the population. It is not really a probability sample because it's a quota-based sample, but can talk about that. There are very few ways to capture data in a moment in time quickly. I mean, doing a survey the old-fashioned way I would argue, be largely impossible because it would have taken forever to get it started. And then there isn't actually a well-defined population parameter of people with disabilities in Canada. There's nothing to compare that to. So that was a problem. So the advantages of doing it this way is that it was very fast because the survey took only a week and a half. It's easier to actually get to people who are underrepresented in a general survey because people with disabilities generally, if you don't actually stratify, you're not going to get this population reflected in the sample. It's cost effective. Again, when you don't know when there's no model to create a disability or chronic health sampling frame, this was very efficient. Now, we were very considerate and looking at what this sample looks like, and we have an entire methodological appendix. If you, I have the link here, but I'd be perfectly happy to email you the link if you email me, where we actually systematically compare the sample with the only two other known Canadian samples, large samples of people with disabilities and chronic health conditions. And the samples are very similar when it comes to these characteristics. So what we did is we looked at Canadians who had different disabilities and different chronic health conditions. So these are physical, cognitive, vision, hearing, emotional, and other conditions that had to last longer than 6 months. Interestingly, 90% of our sample reported more than one disability. So a vast majority of people with disabilities actually have multiple disabilities. We then, using the, this is from the Canadian government, it's list of conditions that makes people the most susceptible to COVID, which tend to be the conditions that we normally associate with chronic health conditions. So asthma, cancer, chronic kidney disease, chronic respiratory disease, diabetes, heart disease, et cetera, et cetera. So these are the individuals that are in the sample. The average age is 49, 53% female. The distribution when it comes to education is very similar to the population and to other surveys. It's slightly under when it comes to Indigenous people. So we only have 2% Indigenous. Again, this would have required a different sort of stratified sample. 53% of the sample is married, but our comparisons to the Statistics Canada data and the Canadian Community Health Survey data shows remarkable similarities with our sample and their samples, which are probability samples. So, you know, we were very confident in the sample's representation. Okay. We also interviewed people. We thought it was really important because to get their voice, particularly because it's a community whose voice is not generally as loud, and it provided us with really more rich understanding of people's actual situation. So we basically selected, so 506 respondents said that they agreed to be contacted again. And we then randomly sampled 100 of them. And then we tried to make sure that of the 50 we did actually interview, that they reflected the breadth of the sample. These interviews were conducted in August, between August and November. So this is a different period in the pandemic. This is actually when it was getting worse because people were worried about the third wave. It's also very weird to talk about this in these terms now because so much has happened since that, you know, in this short period of time. But this is people worried about the third wave. Okay, the interviews were quite in depth. They on average lasted over half an hour with respondents. We then transcribed the interviews using a service called Rev, and then we used software called Deduce to content analyze those interviews. And that was a really interesting process because you really got to see, and I read each one of those transcripts very well from beginning to end. It's actually really troubling to see really the struggle that people, and I want to say this cliche thing, but it's like, oh, how can this happen in Canada? Well, it does happen in Canada, and it's actually quite disturbing. So the interviews, I think, added quite a bit to this project. And then since then, we've also conducted we resurveyed 564 individuals exactly 1 year later to figure out, so you've now been a year in the pandemic, how have your attitudes changed, right? But we're still analyzing that data because we just got it back not long ago. But it's very interesting to see what people how they actually weathered this pandemic. Okay, so during the pandemic, about 35.2% of our respondents were employed full-time, and about 13% were employed part-time. So that's not a lot of people, but that's about what it is with people with disabilities. This is what it is generally. 50% of the population of people with disabilities is employed, and the other half is not. Now, this has important implications, right, for the pandemic in many ways. Only 21.5% of our respondents actually applied for CERB. First of all, most people were not eligible. And first of all, and if you were not employed by the when the pandemic hit, you were not eligible. So again, it's a very liberal regime, means tested, tied to employment. If you are employed, if you're the deserving, you get this. If you're not, really too bad for you, because in Canada, the federal government actually has done very little with disability. They offered a one-time $600 check. That was at the end of, was it this year or last year? But that's it. The rest of it is up to the provinces. That's basically the policy context. I mean, in very short, in some, right? So because most people were either looking for a job or unemployed when the pandemic hit, they were not eligible for the most significant policy intervention that the Canadian government had during COVID, which was CERB. So this is an important piece of information. About 51% of employed respondents were still concerned that they were going to lose their jobs within the next year. So even people actually in good jobs were generally worried. For about 41% of people who were employed thought they were going to lose their jobs in the next month. So this is a significant amount of concern. I mean, almost half the population, basically, of working people didn't know if they were going to have a job next month, felt that they may not have that job next month. So this is also, I think, pretty significant. About 38.3% people in unionized jobs were concerned versus 55% who weren't. So we see that being in more secure employment did obviously help, but it wasn't as though people even in secure jobs were necessarily not concerned about what the nature of their job was going to look like, right? And you have to, again, keep in mind that this is before people were really talking about the world of working from home. This is early, right? So people had no idea what it is that was going to happen to them in the labor market, right? Even people who were employed. And on that note, what we did see is that people's work changed fundamentally during the pandemic. And maybe for some, this is a more permanent change, as we know, right? I mean, hindsight is 2020, but at this point in time, people didn't know what is remote working. I mean, I think academics take that for granted, but for a lot of people, their concept of working from home for their job is totally alien, right? So these people really had to make a transition that they were not well equipped to do, right? 32% of our respondents reported an increase in work hours since March. A lot of these people were already full-time workers. A lot of people told us that they were taking on additional hours because just working from home required a whole bunch of different kind of setting up, and they feel like they don't know how to end the day. And it's very interesting because people were actually working more, and 61% of full-time employees were able to work from home. But 44.2% of part-time employees were able to work from home. That means that people in part-time work were generally less of an advantage when it came to working remotely. I say advantage because one of the things that we end up finding in our interviews is that people with disabilities and chronic health conditions both felt that they wanted to be out of the house and working, but they were also so concerned about getting COVID that they actually found it safer to just stay home and work from home. So this is not obviously an option that was available to everyone, especially frontline workers, people who were working in the service sector, which is a lot of people with disabilities. They didn't even have the option to work remotely, right? They were the only other largest segment of the working population, service workers, other than healthcare workers, that they didn't have a remote option. So it's important to also note that, because it ties back to what I said at the beginning about where are people located in the labor market. Well, because people with disabilities are located in service and food and retail jobs, service jobs, they were not generally offered an opportunity to stay home. And for a lot of people, both working and not working, they reported to us income losses during the pandemic. So for example, we have Glenn, who works in a furniture store, I think in Alberta, if I'm not mistaken, and he has a heart condition and several other disabilities. And I think this summarizes the situation for many workers. And that is, he says, boom, because what happened is when we get back to work, right, they pretty much spun on us that we were getting paid minimum wage and very little commission because people weren't buying furniture. Because before then, we were getting paid commission. I lost pretty well 75% of my income. So people returned to their jobs when there was an easing of restrictions, but they weren't earning the same amount of money that they were earning before. So this put people at even greater disadvantage. So this is showing here basically that how financial security is tied to employment, right? So if you see here that unemployed respondents and those who were unable to work because of COVID reported far worse financial situations. And that's a very important point, no doubt. But even people who were employed still talk to us about the future as being insecure, that they feel that they were going to face financial insecurity, even if they were in a good job. And to us, that really is a wider reflection of Canadian workers more generally. I think a lot of people told us how they become more aware that basically they're just a couple of paychecks away from not being able to pay their bills. So if they lost their job, it's not that they could survive, let alone indefinitely, but even a few months without going into debt. So I think that's a broader message about Canadian workers and where they are financially. So employment, of course, is related to financial insecurity, but so too is pre-existing financial security, right? So those who were able to receive government income supports, people with disabilities, told us they were much better financially secure. Now, these are people who are probably getting disability benefits from the province. That's not the federal government. 47% of respondents reported that COVID affected their ability to pay down debt. And this is where you start getting into, especially in the qualitative interviews, how depressing it is. But people were not paying their mortgages. They weren't paying their rents. They couldn't pay their water and electricity. They couldn't even buy groceries. And a lot of people told us how much they were relying on credit cards to cover the gaps, right, to fill the holes. So this is very problematic because, as I said at the beginning of the presentation, as we start to dig ourselves out of the pandemic, it's not like, snap of the finger, credit card debt disappears. These are things that are now there. They will be there, well after the pandemic is over. Several respondents reported that as I was saying, that this was a reminder that they were only a few paychecks away from not being able to meet their financial obligations. These are even people in good jobs. 47% of respondents who thought their current situation had worsened during the 2020 year thought that it was going to get worse again in 2021. So these are not optimistic people, okay? And just to illustrate that with what our respondents said in their own words, right? So Timothy is a sports instructor with severe asthma, continued to work from home during the pandemic, but had much fewer hours of work. So he told us that he did not carry a lot of debt, but he still didn't feel financially secure with reduced income. He said, "It's been a big hit. I'm worried about that. How long is it going to last for? I've had to use some of my savings. And like I said, I've had to cut back in as many areas as possible. And so, until we get back, I'm not going to feel comfortable." Derek, an educational consultant for international students, has a psoriatic arthritis, and he takes medications that make him immunocompromised. He says, "A lot of business went away once the lockdown happened in March, and it hasn't come back. My revenue has virtually gone to nothing." So yes, impacted, I would say, on a really high scale. And even though they're from a dual income household, so his partner is earning money, they're still down to less than half of what they were earning as a household. So I still have a big mortgage to pay off. So that's my biggest concern. So even people who were employed, it's not that they were riding high during the pandemic. I mean, some people were doing quite fine. That's true. But it's not that this is only a story about employed and unemployed. Even employed people, even individuals in households with dual earners, were facing income losses. And because of that, were telling us about how they don't know what the financial future holds for them. And what's interesting is, as I noted, because disability is so heavily tied to economic well-being, I think it's one of the most important major axes of inequality actually in the world. But, we saw that people who were reporting having multiple disabilities really were the ones that were the most pessimistic about their financial future, right? So those with greater vulnerabilities were exposed to greater insecurity. 30% of people with a single disability reported worsening insecurity, but 40 to 42% of respondents with multiple disability conditions reported facing insecurity. And this is also echoed in how they're thinking about the future, right? People who have multiple disabilities, right, are basically not very optimistic about what 2021 in this case, right, because this was last year, holds for them financially. And remember, again, their relationship with getting government supports was virtually non-existent. So, we had one respondent, for example, tell us, I have to live on $1,600 a month, and you're complaining that you're getting a $2,000 CERB check, right? And so again, just to put that into perspective, it's a really interesting story about, in liberal regimes, who is deserving and who is undeserving, right? So, and what value amount is assigned to that. Okay. So Esther, for example, is a single woman with several disabilities, and she's currently unemployed, has little savings, and amassed about $20,000 in debt. She receives ODSP, which is the Ontario Disability Support Program, and which is money given to low-income workers. And she told us, I don't see that financial thing changing anytime soon. I wish it would, but at the present time, it's not. I'm living each day on the edge, wondering if I can make ends meet tomorrow. And so she relied also very heavily on community supports, community services, including things like people who would do grocery shopping and things like that, right? But those things were also affected by the pandemic. And she says, I'm scared about that because I do need the help, very much so. I need the community services. Even housing that I used to have been able to get help through, they're no longer there. It's sad what COVID's done to everybody. So what makes people more hopeful about their post-pandemic economic futures? Well, I think it's important to know because it tells us something more generally about our society. And basically that's jobs, jobs, jobs. People who were employed definitely felt better about their situation, right? 34% of those employed expressed feelings of worsening future insecurity compared to 57% of people who are unemployed. Now, the other second most important factor was government support. So 26% who receive a disability tax credit, because in Canada, in order to receive benefits, the Canada Revenue Agency has to classify you as someone who gets a disability tax credit, right? So people who don't receive a DTC credit said things were going to get worse compared to 16% who did. CERB also helped, but remember, only 21.6% of our sample, something like that, 22% roughly, of our sample actually applied for CERB. Most people were not eligible anyway for CERB in our sample, right? Because they were looking for work. A lot of people were looking for work when the pandemic hit, so that makes them ineligible for CERB. And we found some less significant effects when it comes to savings and family supports, but they're still nonetheless important. But really, employment and government support were the key things that help people assuage people's fears about financial insecurity. Now,
sorry for the interruption, David, but you may need to wrap up in about one or 2 minutes.
Oh, okay. I will be very fast. Okay, so because of all of these economic problems, it's probably not surprising to know that people with disabilities and chronic health conditions were severely impacted when it came to their mental health. Okay, 38.2% of respondents reported increases in anxiety. 43% told us that it's their finances that led to that increase in anxiety. And so you see a very strong connection between a few factors. One is the heightened concern about getting COVID because people with disabilities are more susceptible, and their economic situation is also impacting their mental health. Okay, I'm going to skip this. I just wanted to say one thing about people and their policy preferences. People actually their experiences didn't really shape who they politically supported. In fact, most people who voted liberal again in the next election, because we asked that question in our second survey. This was just before the election, okay? People really were down party lines when it came to whether they thought the Canadian government did a good job or a bad job. Conservatives really don't like the Liberal government. They don't like Trudeau, and that was very obvious. And they also tied the pandemic policy responses to things like government overreach and, it's just another Liberal scam, or it's just abuse and all this. So it's very interesting. So in fact, what ends up driving people's attitudes is really not the pandemic itself, but it's their pre-existing partisan attitudes. So just to conclude, I think what's important is that moving forward, we should think about what we want the future to look like. People keep talking about returning to normal. Well, for a lot of people, normal wasn't a great place. right? I mean, and so this could be a way to think about, COVID could be a way to think about ways to make things better, right? It's an exogenous shock. It should make us think about what things are like. And instead of talking about returning to the status quo or returning to things how they used to be, I think it's a very selfish thing to say, because for many people, returning to what things used to be like isn't a particularly great thing. So why not use this as an opportunity, thinking about this as an opportunity, like, for example, universal basic income, which CERB kind of was like for some people, ways to think about how to improve our safety net, because surely we will have other exogenous shocks, whether that's a health crisis or a economic crisis, and we're going to have this conversation all over again. So I don't want to leave things on a pessimistic note, but there could be an optimistic message here as well. Thank you for listening. I'm sorry for going over.
Now let me introduce our second speaker, Triun Lee, who is a PhD student in the Social and Behavioral Health Sciences program at the Dalai Lama School of Public Health, University of Toronto. Prior to her doctoral studies, Triun worked in a variety of research settings, such as a scholar activist in People's Health Institute, a nonprofit research institute in South Korea, focusing on health inequities and precarious employment and health. Triun's doctoral research addresses the question of work-related injuries and deaths in South Korea, critically probing the social, political, and economic structures behind the development of the regulatory regime for health and safety at work in the country. Triun is engaged in a variety of projects, including the health and health inequity implications of informal employment in labor market, employment in a global context, public health activism for health and safety at work, and the Korean government's response to the COVID-19 pandemic, and its impact on the nation's public healthcare system and socioeconomically disadvantaged people. So please welcome Triun Lee, who will speak about the impact of the COVID-19 pandemic on the public healthcare system and socioeconomically disadvantaged people in South Korea.
Thank you so much for inviting me to this panel. And I'm a PhD student candidate at the Dalai Lama School of Public Health, and I came back to Korea when the schools started to be closed due to the pandemic. In Korea, I had the opportunity to participate in a research project funded by the National Medical Center in Seoul to investigate a particular healthcare system response to the pandemic made by the Korean government. And this research project is still ongoing. And in this presentation, I'm going to show you some preliminary findings of the research project. And 4 PhD students, including myself, are participating in the project as a research assistant under the supervision of Dr. Myung-hee Kim from the National Medical Center. So I assume that many of you know that Korea has been praised for its successful containment of COVID-19, and the country has been pointed out as one of a few countries that have managed to minimize the health and economic impacts of COVID-19 outbreak through quick, effective, and targeted measures, thereby avoiding full lockdowns. So 3T model has been mentioned as fundamental to the success of the Korean approach. First, the Korean government was able to set up large-scale population testing because there were already many biotechnology companies for testing and producing test kits. And they were created in the aftermath of the Middle East respiratory syndrome crisis in 2015. And second, widespread contact tracing was conducted by contact tracer who were given access to different types of data, which of course posed ethical challenges in many other countries. The contact tracer identified almost all the people a person with a positive for the virus may have in contact with. And these 2 elements allow the country to control the outbreak and prevented the Korea's healthcare system from being overwhelmed. And the third element was healthcare system capacity to treat patients infected with COVID-19. And it was frequently mentioned that having a high number of acute care hospital beds per population is a useful proxy of the capacity of a nation's healthcare system to cope with a pandemic. So here is a bar chart that outlines the number of acute care hospital beds per 1,000 people in OECD country. As you can see in the chart, Korea had the highest number of hospital beds with over 7 beds per 1,000 people in 2019, which was above the OECD average and the estimate of Canada. But however, ironically in Korea, we have heard news reports repeatedly, and the government has repeatedly announced that the medical system was on the brink of collapse due to the surge in coronavirus cases. But these reports were delivered when there were less than 700 newly confirmed cases on December 10 last year, and just over 1,000 cases on December 16. So in this context, one question arises. So why would a country like Korea with the highest number of hospital beds fear the collapse of the medical system with the daily number of newly confirmed cases merely over 1,000? So how can we explain this puzzle? So this puzzle is very simple actually and straightforward. It was because the Korean government only mobilized beds in public hospitals for COVID-19 care. The government exclusively designated public hospital for COVID-19 care and ordered all or a considerable portion of beds in public hospital to be evacuated. But as you can see in this pie chart on the right, there were 221 public hospitals in Korea in 2019, which accounted for only 5.5% of all hospitals. And compared to other OECD countries, Korea had the lowest number of beds in public hospital with 1.2 beds per 1,000 people, which was far less than the OECD average at 2.9 beds. And as a result, 85% of the designated COVID-19 hospitals were public hospitals, and almost 70% of patients with coronavirus were hospitalized in public hospitals. The government did not actively mobilize private hospitals, accounting for the majority of hospitals in the country. Rather, the government made every effort to prevent infected people from entering those private hospitals so that private hospitals were able to business as usual during this global public health crisis. In this research, we problematize such a response, mainly because public hospitals in Korea have long been a safety net for most marginalized members of the society. There have been underinvestment in public healthcare system and also in social and community care in Korea. So public hospitals have played a residual role in the nation's healthcare system. They were reduced into a poor quality care facility for houseless or frail elderly in near poverty who has been bedridden. So in 2017, about 25% of inpatient in local medical center were medical aid beneficiary, which was significantly higher than that in private hospital. And in the case of Seoul Dongbu Hospital, 66% of inpatient were medical aid beneficiary in December 2019. Considering that medical aid beneficiary are only 3% of the entire population in Korea, these are substantial numbers. And at the same time, various social supports and services were provided to vulnerable patients through public hospitals. This was one of the critical factors that motivated disadvantaged people to disproportionately rely on public hospital rather than private hospital. And that's why our research team looked into this particular healthcare system response to the pandemic, that is the evacuation of public hospital beds, and its unequal impacts on socioeconomically disadvantaged people in Korea. So we had two specific research questions. The first was about the processes that were taken by public hospitals while they were securing their beds for COVID-19 patients and driving out their pre-existing patient. And the second question was about the impacts of such a response on both the nation's already fragile public healthcare system and socioeconomically disadvantaged people. So we've completed semi-structured interview with two groups, including 16 healthcare providers from affected public hospital and 12 advocates from civil society organizations who represented socioeconomically marginalized population. Although the analysis is still ongoing, I will present some preliminary findings from the qualitative research part. And we've just initiated quantitative data analysis using public hospital database and national health insurance database to examine inequities in healthcare utilization and health outcomes during the pandemic. So I first wanted to highlight several important features of the evacuation processes in designated COVID-19 hospital. First of all, the evacuation of hospital beds was not voluntary, but enforced only on public hospital according to an administrative order. And the public hospital had to evacuate all or a considerable portion of their beds in 1 to 2 weeks. And most importantly, the affected people did not have a voice in this decision-making process. And most pre-existing patients who have been hospitalized in public hospitals before the evacuation order were transferred or discharged without sufficient consideration for severity of illness or care resources of individuals. And expectedly, the patient transfers were particularly difficult for the houseless and mental illness patient and undocumented migrants without a supportive family and social network, and people living in near poverty who cannot afford co-payments, especially frail elderly in near poverty who has been bedridden and thus considered unremunerative by private hospital, and those with multiple comorbidities. And this is an extract from an interview with an advocate for people with disabilities. A person with disability broke his ankle and was staying in an ICU unit of a public hospital, waiting for his second surgery. One morning, the public hospital was suddenly designated for COVID-19 care and required to immediately evacuate all beds. And in that afternoon, he was transferred to a private hospital, but his information was not shared and communicated at all. Anyway, he got the second surgery at the private hospital, but discharged without a necessary rehabilitation. But he was a resident of an assisted housing and was in no condition to get a proper care for rehabilitation at home. So he had no mobility difficulty before this incident, but now he's living in a wheelchair. So this is not just one exceptional case. There are other similar patient experiences that were caused by the evacuation of beds in public hospitals, but many patient stories remain invisible and unheard until now. So additionally, we have found many other challenges from the standpoint of patients in socioeconomically vulnerable condition. First, continuity of care was disrupted due to uncoordinated care during the processes of patient transfer or discharge. Second, as I mentioned in the earlier slides, each hospital has diverse social support and services for vulnerable patients, including co-payment relief program and after discharge management of low-income frail elderly. However, all those programs were suspended as public hospitals were designated for COVID-19 care. Those services has no portability, meaning that they were provider-centered, not people-centered. So people in poverty avoided treatment at private hospital, not only because they cannot afford co-payment, but also because private hospitals are considered culturally kind of unacceptable and less sensitive to their specific needs. And private hospitals themselves have been implicitly refusing the houseless, migrant workers, and those in near poverty. And lastly, many pre-existing patients hospitalized in public hospitals needed social care services after discharge. But as I mentioned, because Korea has a very weak social and community care system before the pandemic, they were left unattended in a substandard housing and being completely isolated. It was not only patients, but also public hospitals that were affected by the evacuation order. First of all, quality of care was impaired due to the disrupted continuity of care. In early stages of the evacuation, even outpatient services were suspended. So public hospital lost not only inpatient, but also regular outpatients. And it ultimately broke the regular doctor-patient relationship. Even after public hospital resumed the provision of outpatient services, a considerable portion of regular patients never returned. The loss of staff morality was of enormous concern. Many medical staffs were drained into private hospitals, especially surgeons who were in fear of skill loss, left public hospital where they were no longer able to perform surgery. And and because the public hospital physicians were paid by piece rate payment scheme, like other physicians in private hospital, the staff, especially physicians, expressed growing complaints about wage reduction. Wage reduction occurred due to the decline in the number of their regular patients. And the government, of course, provided compensation for designated COVID-19 hospital. But it should be noted that the long-term support for the capability loss was not included in the government compensation. Thus, most interview participants expressed their concerns over capability loss and sustainability of public hospital in a post-pandemic future. And finally, during the pandemic, the public has developed an ambivalent attitude toward public hospital. On the one hand, public hospital gained reputation as a safeguard against the pandemic. This public trust is an unprecedented, considering that public hospitals have long been considered as a poor quality care facility only for those in poverty. But on the other hand, the government order that mobilized only beds in public hospital generated the social stigma of infectious disease hospital. And at the same time, the regular patients of public hospital became very skeptical about the value of public hospital as a usual source of care. And all these are combined to cause a slow recovery of outpatient visits to public hospital and consequently to threaten the financial sustainability of public hospital. We are yet to know the implication of such an ambivalent attitude of the public towards public hospitals, whether it contributes to strengthening the public healthcare system or further marginalizing public hospitals. So this bar chart outlines the monthly average number of outpatient visits to some of the public hospitals. And I compared the monthly averages for the year before the pandemic and January to June 2021. These are several public hospitals that are undergoing a significant decline in the number of outpatient visits. For example, Seoul Dongbu Hospital, Suwon Hospital, Paju, and Seoul Bukbu Hospital have experienced more than 50% reduction in outpatient visits in the first half of this year compared to 2019. And Seoul Dongbu Hospital, as I mentioned, has been known for a safety net hospital for socioeconomically disadvantaged people. And as I said, in December 2019, medical aid beneficiaries accounted for 66% of all hospital inpatients. Considering that medical aid beneficiaries account for only 3% of the entire population in Korea, it was not an exaggeration to say that Seoul Dongbu Hospital served mostly the vulnerable communities. The blue line here is a total number of admission for National Health Insurance members, non-poverty population. And the red line is the total number of admission for medical aid beneficiary. After Dongbu Hospital was designated as a COVID-19 hospital in December last year, NHI members overtook medical aid beneficiary in the number of hospital admission and inpatient. And those NHI members imported since December were all COVID-19 patients. And the medical aid beneficiary who left the hospital since December are the ones who need our attention. So how are they doing after transfer or discharge from the public hospital? Did they get an appropriate care after leaving the public hospitals? Will they return to the public hospital? So the next step of our research project is to trace their healthcare utilization and health outcomes after being transferred or discharged from public hospital. So these preliminary findings from our in-depth interviews demonstrate that the evacuation of public hospital beds for COVID-19 care maintained and reinforced the fragility of the nation's already fragile public healthcare system, and also contributed to strengthening social and health inequities. It is quite clear who benefits and who loses from such a healthcare system response. So first, the government could efficiently and effectively mobilize hospital beds so that and maintaining the usual function of private dominant healthcare system. And second, private hospital could business as usual, legitimately avoiding the care of COVID-19 patients. And third, the general public could have a safeguard against COVID-19 while using healthcare services in private hospital on a business as usual basis. And both those in socioeconomically vulnerable conditions encountered with unmet needs for social and medical care, and they were excluded from the decision-making process that disproportionately affected their health and well-being. And finally, public hospital, on the one hand, got the short-term government compensation for COVID-19 care, and also they were able to kick out troublemakers and bad blockers while gaining public reputation as a safeguard against the global pandemic. On the other hand, the regular doctor-patient relationship in public hospital was broken, and the reduction in outpatient and inpatient services led to capability loss and financial unsustainability. So in conclusion, public hospitals in Korea have played a residual role in the nation's healthcare system, primarily as a usual source of care for socioeconomically marginalized people. In this context, the government mobilization of public hospitals for COVID-19 care has discriminately affected people in socioeconomically vulnerable conditions. The few marginalized people have been sacrificed for the public, and the marginalized public healthcare system has been sacrificed for the private dominant healthcare system. And South Korea's success in containing COVID-19 pandemic has made the voices of marginalized people unheard, and the collapse of the public healthcare system invisible until now. So based on our finding, we kind of are urging the need for sharing the burden of COVID-19 care equally by all hospitals, including public and private hospitals. And more fundamentally, we are arguing that the publicness in the nation's entire healthcare system should be strengthened. So yeah, that's it. Thank you very much for your attention. Yeah.
While people gather their thoughts to formulate their questions, let me take advantage of my position as the chair and then and ask a question, one each to David and Triun. The question that I have for David is, I mean, I think it's not really surprising that the policy for people with disability is not really great, and it's obvious that they will be doing much more difficult. They will be facing much more difficulties during this kind of pandemic situation. So why isn't there any serious consideration or in the government to do something more proactively? Is it they don't have resources, or they just don't care about these people? So what is the hurdle in between these needs, real needs out there, and lack of more proactive response from the government? And my question for Triun is, I know this debate about public healthcare and private healthcare is really intense in South Korea. So I was wondering whether the reason why the government relied only on public hospitals was because private hospitals resisted, or they just did not even consider working with private hospitals in the COVID context. So what's the political dynamics operating here between the government, public hospitals, and private hospitals? David, do you want to go first?
Okay, sure. I mean, I think that's the the $64,000 question. I think there's two ways, interrelated ways to look at it. I mean, one is institutional, the other one is cultural. I think institutionally, I think we are in this kind of liberal welfare regime that is basically founded on the basis of who is most deserving of support. So I think that's a part of that is, it's means tested, who is a person with a disability. The other is jurisdictional, right? The federal government, I mean, especially in Canadian politics, right? The federal government will say, well, this is a provincial matter, which it is. I mean, government benefit, when it comes to benefits, people with disabilities are directly in dialogue with their respective province, not with the federal government. So I think there's this institutional problem, right? And the other problem, I think institutional problem is, you can talk about rights and all that, and that's really important. But in the end, rights are not the same as, it's not the same policy question, as is, for example, what kinds of actual social welfare supports do we have in place, right? Because you can talk about rights and equality and all that, but if you're not going to provide the resources, right, because of these institutional blockades or whatever, then you're not going to really have the kinds of outcomes that you kind of would hope. And I think the point that what you started your question with, you kind of about, should we be surprised? Oh, it's not surprising. I think that's exactly the problem, is that it's not surprising. I think this is what's expected, right? And culturally, I think people just don't think of people with disabilities as, and this is a longstanding thing, as people who actually do work, who are productive. They're basically still thought of as people who are a burden on the state. And so I think that's a big part of the problem in I don't think just Canada, but I think in most places where policies are very much tied to who you are and what you contribute. If you're seen as someone who doesn't contribute socially, economically, then it becomes a lot easier to really restrict that. And you see that here, where the federal government's involvement was, here's $600. It was an enhanced GST check. That's what you're getting. And I mean, I didn't really talk about how the cost of living has gone up for a lot of people. Medication fees, dispensing fees were high. Like, lots of things were happening, and basically people's incomes weren't improving. So you end up, and again, instead of being non-surprising, we should be thinking more of, this is terrible. Why is this happening? But I think for me, that's really at the heart of it, is like, why are we not surprised, right?
Mm-hmm. Thank you. Triun?
Yes, thanks for your question. It is really kind of important question. Actually, I we are seeing the Korean government, this particular response in the continuum of the Korean government approach to social and health services. So when the developmental state in 1970s introduced medical insurance system in 1997 in Korea, there was a kind of a surge in demand of healthcare because the medical health insurance reduces the financial kind of barrier to healthcare. But the government chose to rely on private healthcare provider in response to the increasing demand, rather than expanding investment in public healthcare system. It was a political choice driven by kind of neoliberalism, and they didn't invest. They rather investing in the developing the private hospital, private healthcare kind of providers. They provided government subsidy for building private hospitals. So this is in the continuum of this particular developmentalist Korean government kind of approach to not only health services, but also social services. They are really reluctant to providing individual services. They always want to provide social and health services through private providers. And as a result, Korea has a private dominant healthcare system, and the government compensates the designated COVID-19 hospital for the loss. In other words, in proportion to the average monthly revenue of each hospital in the past year. So if the government order all hospitals to provide care to COVID-19 patients, the government compensation will be a very significant burden on government. So in the pre-existing environment, the private dominant healthcare system and the private hospital seeking they are non-for-profit by law, but they are actually doing the profit-seeking behavioral. So there are some political economic context of the Korean healthcare system. Yeah.
Thank you so much. Hyuncho?
Oh yeah. Thank you for presentation for both speakers, and I have some questions to David. I first thank you for elaborating how the pre-existing conditions of financial and job insecurity have both past dependently impacted to the life of people with disabilities in this pandemic situation. And I also have been I have been participating in disability movement in South Korea, so I could hear how it has been, very how it has been a difficult time for those people. And so methodologically, I wonder if I understand correctly, there was some eligibility criteria for your survey. So methodologically, I would like to hear more about how did you design those criteria, and how did you find the potential respondents in that online settings. And I'm also wondering how if there were any, because I'm from geography department, so I'm wondering is there any distinctive different response patterns among different provinces. And I also would like to hear more. It's not maybe directly related to your presentation for today, but I would like to hear more how people with disabilities, especially people with multiple disabilities in Canada and who are working from home, have had any, how did have had the community services and care assistance during the pandemic. And lastly, I would like to hear more how on the mental health and its impact for the people with disabilities during the pandemic. So there are several questions, but yeah, I'd like to really hear more about your presentations. And thank you so much for today's.
No, and thank you for this
talk.
really great set of questions. And I mean, I will, if you, I mean, I will, maybe I'll do it in the chat. I will send you links to the, just like a, without the paywall of the publications that came out of this, and also the link to the methodological appendix. I think that would be helpful. But your question about how we basically measure disability, we basically use the, I guess the standard measure of 6 different types of disabilities. And if a person identifies as having one of these disabilities that lasts more than 6 months. So they weren't asked one question, they were asked many questions that we then compile together. So that way we knew exactly what the nature of the disability was. And we made, because our sample only contains people who had to have affirmatively responded to any one of those questions to be included in the sample, and also the chronic health conditions. It just so happens that 90% of the sample, we didn't set out for this to happen, 90% of our sample reported having more than one disability. So again, I think that that's more telling about how people generally experience disability in more complex ways, and we'd like to think it's not just one thing, right? So we separated each and one of those types of disabilities out, and each one of those chronic health conditions out. So we both know what specifically a person's disability is, and also how many other types of disabilities they identified as having, right? So, and we also asked about intensity, but we didn't really find, there wasn't that much actually variation in how across disability type in our sample with different outcomes. But I will say, what was the second question?
Oh, sorry. Was there any difference response pattern doing up?
Regionally.
The difference, regions.
Yes. So the short answer is yes, but in a very specific way that I didn't talk that much about. It's in the slides though, but what we found very interesting is when it came to people's attitudes about policy responses, regionality did matter. People in the prairie provinces, who are the most anti-liberal government, right? Historically in Canada, that's been the case, were the people who were the most critical of Trudeau and of the Liberals. There was the most dissent and the most just criticism, but also party ideology. So if you were a conservative, so we did find regionality mattered in that way. We didn't find that region mattered that much in how people understood their economic situation, which I guess is interesting because there is quite a bit of variance in what kinds of benefits province provide. Some of them are more generous than others. But we didn't really find those effects to be great. We found that region really mattered when it came to people's attitudes about policy, federal government policy. And so that was very interesting there. In fact, it was the second most important predictor other than party ideology. But in other regards, we didn't really see that much of an effect. I think that's also because people, we've asked a variety of different questions in the survey. One of the things that we found very interesting, and we didn't explore all that much yet, is that people also were I don't want to use the word confused, but people conflate, let's use that word, it's better, conflate who is responsible, right? Is it the province? Is it the city? Is it the federal government? And especially when you start asking questions more about the politics around it, people confused province and the federal government, and others were basically talking about basically a conservative province, prime minister, premier, but tying it into federal politics, which is a separate thing. So I think a lot of people also didn't know how to tie the pandemic to which government, level of government. So that's very interesting as well. There was a question about mental health. Mental health actually is probably one of the most important understudied areas when it comes to disability, because first of all, we do know from epidemiologists and scholars of mental health, and I don't consider myself either of those things, but we do know already that people with disabilities face certain barriers. I mean, one of those really important barriers is isolation, right? People feel more isolated. A lot of people, through the desire and want to be independent, also during the pandemic, were literally left alone because for people who do rely on care workers were no longer going to people's homes. We have people in our department like Cynthia Cranford and Ido Peng, basically, who study care work. And the thing about care work is that a lot of care workers were also working in nursing homes, which was a significant problem for the spread of COVID. And we're also working in home care. And so there was on both the supply and demand side, people with disabilities didn't want the care workers in the homes because they were worried. Home care workers didn't want to go into the homes because they were worried. So basically people weren't getting care. The other problem is that they were completely cut off from any other kind of appointment. So we had people who couldn't make mental health appointments were canceled, even just like physical care, people who had regular blood tests that they needed to get done had problems. A lot of people complained to us about that, they had telecare, like basically online, which most people found wholly inadequate. So it's not only that they weren't receiving care, but there was no contact with other people. There were some people who told us they haven't seen their kids in a year. I mean, some people hadn't seen their partner. They decided to just quarantine because of their jobs. They didn't want to bring it into the home. So people were very lonely, very isolated. And not only that, but on top of that, because of their vulnerable group, more exposed and more at risk, not only of getting COVID, but if they do get COVID, the complications are more severe. So people are, of course, very stressed about this, but they're also stressed about their financial situation. So that mental health situation is quite horrible. And what's interesting in Canada is right before the pandemic, there was this whole campaign about mental health is a broad problem in Canada. There's these huge campaigns, even private companies were getting involved, and these, our telecommunications company Bell had the Let's Talk campaign about mental health. Mental health was all over the agenda. And then COVID happened. And then people stopped talking about mental health. But mental health during the pandemic is really important because people like to talk about getting the vaccine, and that's going to really, put an end to things, but it's not going to help. It's not going to just put an end to people's mental health problems. And this is what I think people mean when they say, what about the long-term impacts? It's financial, it's mental health, right? It's personal, social, right? These are not, I know it's weird to say this now because we're still thinking about the vaccine and the cure, but these are really much harder things actually to cure because there's no immediate, there's no vaccine for mental health. There's no vaccine to get you out of credit card debt that you amassed during the pandemic. So these are going to be the things we're going to have to face. We are already dealing with it, but this is going to have to come up as an important political agenda item, policy agenda item. I don't know if I answered all your questions.
Oh, yeah.
Okay.
Yeah.
But
Thank you so much.
This is these are the issues, right? I think this is,
Yeah, true. Yeah, there are no vaccines for mental health. So
No.
true.
Yeah.
Thank you. Perhaps we can take one more question if anyone has.
I thought that historically there has been a long engagement of private social welfare sector in Korea's social welfare policies and institutions. I think so. It was quite surprising to me that there was no many private hospital engagement during the pandemic, and and I thought that many of I'm not sure, but I thought that many of private social welfare foundations they already have some nursing homes or sanitariums for those so-called social welfare populations, and they have many hospitals, I thought. So I was just wondering and there were many problems during the sorry, and I thought that they have some beds for helping this emergent situation. So I thought that would there have any engagement of those social welfare associations or any social welfare related hospitals or other nursing homes.
Yeah, there are several private hospital, nursing hospital, which participated as a COVID-19 hospital. They voluntarily participate in this program, but it was a voluntary, and most of them were motivated to do this because they didn't have many patients before the pandemic, and they knew that they can get the government compensation, and there are a few kind of private hospitals that participated in as a COVID-19 hospital. And I wanted to mention that the government also ordered just once in the last minute when there was I think second or third kind of wave of the COVID-19. The government ordered several private hospitals to secure beds for COVID-19, but it was the last minute, and they also resisted. And even the private hospital association or something request the government to evacuate all the public hospitals beds to treat the surging patient, and they didn't have the idea that there are marginalized members of the society hospitalized in public hospital, and they don't understand how public hospital have functioned as a safety net in South Korea. And also government didn't actually take any action, and they don't know where all these patients have gone after they discharge or just refer to other private hospital. And there are some private hospital, but the mandatory kind of order of the government was only on the public hospitals. Yeah.
Okay. Thank you so much. It's 5:48, so I think it's time to wrap it up. Again, thank you, David, and thank you, Triun, for sharing your research, which touches upon the most vulnerable people and their vulnerabilities and insecurities are rather exacerbating during the COVID pandemic. And I really learned a lot, and beyond what we usually talk about, COVID-19. So I hope we can continue this conversation because I think it's really important that we give voice to these people who are usually unheard in public or official discussion of the pandemic. So thank you so much. And just another reminder, if you have time, please participate in the online survey that the Consulate General is conducting, is in the chat. So I'll really appreciate that. Okay, thank you so much, and have a great weekend in Korea and also here in Toronto.
Thank you.
Thank you so much.
Thanks,
Thank you so much.
Bye, David. Have a nice
everyone.
weekend.
Bye.